Hi, this is Dr. Kathy Robinson, and this is a presentation on the neurologic CNS conditions you would find in acutely ill patients. I love to include this piece of art in this presentation because I think it is so evocative, and I think it's important for us not to get lost in just the science of the disease, but in how it adversely affects our patients. The first thing we'll talk about is stroke. And of course, stroke could be roughly divided into three categories: ischemic thrombotic, hemorrhagic, and embolic. Ischemic thrombotic are obviously the most common type of stroke, about 80% of all strokes, and the combination of hypertension and atherosclerosis accounts for basically all of these strokes. The risk factors are exactly the same as for atherosclerotic heart disease, and current terminology is calling this type of stroke a brain attack because it is the same process that is occurring in patients during heart attacks. Now, this is a classic concept that was identified in the 70s called the stroke belt, and the CDC identified this concept. As you can see, the stroke belt includes the southeastern United States. It does not include Florida, interestingly enough, and in this particular iteration, Arkansas has been added. There is talk now of beginning to add Texas and possibly Arizona to the stroke belt. Now, there's been a lot of investigation as to why this stroke belt things are so pronounced here, and this really is reflecting not incidence of stroke, but mortality related with stroke. We don't have a firm reason yet. A lot of things are suspected. Individuals in this part of the country tend to be less well educated, and strokes tend to occur more frequently in the less well educated. They tend to be of a poorer socioeconomic class. There is a concentration of African Americans in this part of the country. So are we less athletic in the South? Do we not, exercise as much? Outdoor activities are different in the South. We're not snow skiing. We're not cross-country skiing. We're not mountain climbing or rock climbing, so it's too hot, I guess. I don't know. We don't really know the reason for this, but we know it's true, and it's been true for a very long time. Now, there is some conversation now, like I said, adding Arkansas or Texas and Arizona, but also that the stroke belt is dissipating across the country. So that's related to obesity primarily. Now, this particular picture happens to be for white males. You can get one of these slides for every group you want to look at. And this was just the first on the list, so I picked it. And as you can see here, the mortality is still highly concentrated, and those highly colored areas are the ones with the worst mortality in the southeast. But you can very clearly also see the extension to Arkansas, Texas, and in this case, Oklahoma. Now, in this particular group, Arizona has not been added in, but I would suspect that white males aren't the stroke problem in Arizona. That would be people of Hispanic descent and American Indians. So they would not be necessarily reflected in this particular slide. Now, this is an interesting slide that the CDC has just identified what they are calling a diabetes belt, and this is related to incidence and prevalence of diabetes. And you can see that here, just being yellow means that over 9% of your states have diabetes. And then if you're red, these are counties in which more than 11% of the patients have been diagnosed with diabetes. So again, we have here, Arkansas has this very high concentration of diabetes right along this edge here. And then we also have a high concentration in here. What's interesting, of course, is how similar, not identical, but how similar this is to the stroke map. Now, we do have over 730,000 cases of strokes per year. And while we think of this as a disease of the elderly, actually about 30% of all stroke of all patients who experience a stroke are under 65 years of age. It is the third leading cause of death in the United States, and these data come from the American Heart Association. So let's talk about a term that's familiar to all of us, TIAs, which of course stands for a transient ischemic attack. And the traditional definition of a TIA was a neurological defect that occurred and persisted for no more than 24 hours. We also had an older term called RIDS, or reversible intermittent neuro deficit, which was a longer TIA that lasted a day or two. Well, quite a few of the experts have proposed a new definition. And the new definition, one, it eliminates the RIND from the equation. And the new definition of TIA is a brief episode of neurological dysfunction caused by focal brain or retinal ischemia, with clinical symptoms typically lasting less than 1 hour and without evidence of acute infarction. Now, and this has been endorsed by the American Heart Association, the Stroke Association, but not really adopted. And that's because some clinicians have difficulty with this. Is we do understand that things we used to call TIAs or RINDs may have indeed been strokes. In other words, that they resulted in infarction, and the old terminology did not account for that. So this terminology accounts for that, but of course the only way you can diagnose infarction is with imaging. And so it is more complex and more expensive to diagnose a TIA than it would have been without imaging. So that's some of the debate around this question, but there is no debate that somebody who is experiencing this type of defect, Okay, I'd like to also mention dementias. And for those of you in critical care, know that we have a lot of focus now on delirium identification and delirium management in the critical care area. The difference between delirium and dementia, just to remind you, is that delirium is a reversible acute onset cognitive dysfunction. It may be related to over or under stimulation. It may be related to drug or toxic exposures, but delirium typically is reversible. Dementia, which usually has a vascular cause, is not reversible. It's a steady downward trajectory. So dementia is a permanent loss of cognitive function. It is a slow onset and chronic progression, whereas delirium is an acute onset.
Okay, one of the characteristics of Alzheimer's disease, and you know we've all heard the expression that you can't diagnose it until after death, and what they would look for after death is evidence of these neurofibrillary tangles, or tangles of these denatured proteins in the brain. Sometimes those are so dense they're actually called plaques, and the number and amount of these is somewhat but not absolutely related to symptomatology. There's an interesting study that's been going on for a very long time called the NUNS study. And of course, religious sisters have a fairly stable life. They don't smoke, they don't drink, they don't do drugs. They typically live quite long. And the sisters of this one congregation, the School Sisters of Notre Dame, have agreed to have annual assessment of their cognitive abilities. So they go through, and their physical status. So they go through quite an extensive evaluation every year. And then upon death, they do autopsies, including autopsies of the brain. And there have been some really, really interesting findings there. For instance, and this particular congregation has very, very good records on the sisters. And one of the things that this group of women largely entered the congregation when they were in their 18, 19, 20s, very young women. And one of the things they had to do was write an essay. And they have actually, and those essays have all been retained in the files, and they've actually done studies of biologic sisters who became religious sisters, one of whom had ultimately developed Alzheimer's and the other who did not. And they went back and tracked through all of the data they had on these sisters, including these admission essays, and found that the complexity of thought in the admission essay of the sister who ultimately developed Alzheimer's was much less than the complexity of thought and expression in the sister who did not. So that was a very interesting finding. But another interesting finding they've had is that, and again, in a religious congregation, sisters keep active. Even when they're retired, they're still cooking, caring for others, uh, running small businesses out of the convent, whatever. They're always, they never just stop working, and they never stop using their brains. There's always, um, spiritual reading, reading the scripture, listening to sermons, stuff like that. So anyhow, they would have these sisters who had significant cognitive decline, and then they would also have sisters who had minimal or no cognitive decline. And then when these sisters passed on and they looked at their brains, sometimes the brains of the sisters with no cognitive decline looked almost as bad as the sisters with a cognitive decline. So just the presence of the tangles and the plaques isn't the only factor. Very, very complicated disease. And of course we know how this presents, initially with forgetfulness, gradually real emotional lability, disorientation, inability to plan or make judgments, to problem solve, and then ultimately inability to care for oneself. It starts very slowly and then of course is relentless and progressive. Ordinarily this isn't a first diagnosis, it's sort of a diagnosis of last resort after all other factors have been ruled out. This is an illustration of some of the things that happen in the brains. For instance, this amyloid plaque, which is this large, looks like little red sticks here. And you can see these amyloid plaques are quite large related to the cells. And this one's completely covering an axon in this illustration, so you could see how that could really, really interfere with communication between the axon and the next nerve cell, or wherever it was supposed to be going. In addition to these other smaller substances, the oligomers and the protofibrils, which seem to be earlier stages of the amyloid deposits, or just a different kind of an abnormal amyloid deposit, and those things can interfere with the synaptic action itself, as well as cell-to-cell communication. You could see maybe even a degradation of dendrites on the cell. These are harder to spot than the amyloid plaques, and they may be present before the large plaques. There's another disorder called mild cognitive impairment, which is greater than the normal loss of memory, of age-related memory, but not as much as Alzheimer's disease. And so these patients are sort of like in a very early, like Alzheimer's state, or they do definitely have a cognitive impairment, but only in the, say, the area of memory. And they may progress, they may not. It's definitely not considered pre-Alzheimer's. It's just some of them will progress and some will not. And I have to wonder if maybe some of these earlier or these smaller changes are present in those people, but for whatever reason, not the large change of the plaque. Bottom line is we really don't know yet, but we're working on it. And of course, the big question in science is not so much about the plaque itself. We know that it's there, but why did that happen? These plaques are formed by the unfolding of proteins, and proteins are classically folded because they're such big molecules. So the question has to be, we've already learned we really can't, if we refold the protein, it doesn't help. We learned that in laboratory science. And so now what we have to figure is, what is the reason proteins unfold in the first place? And of course, we're seeing amyloid depositions in the pancreas of type 2 diabetes as well. And there have been individuals who have suggested that we know there's a strong epidemiologic link between Alzheimer's and diabetes. It's been, I don't know if jokingly is the right word, but it's been referred to in an unofficial way as diabetes type 3 or type 4. And so that question of what causes this unfolding of these proteins in certain people but not others is extremely important. You will be asked in your own life, and you will be asked as clinicians, is there anything I can do to prevent getting Alzheimer's? And truly, there's no good answer to that, but what we know is that all those things that are good for your blood sugar and good for your heart, in other words, those healthy lifestyle decisions about eating and exercise, all promote brain health. And this may have been part of the phenomena in these sisters who had brains that looked like they should be much more impaired than they were. They were keeping active, they were eating well, they weren't smoking, and so on and so forth. We don't know. But that's what I always tell people. You know, we don't have an exact answer, but we know all the stuff that we do that's good for our heart or good for our diabetes is good for our brain as well. And actually, that's a pretty good answer. This is another chart that I think Michelle found. These are mini mental status examination scores, and as you know, anything below 24 is somewhat abnormal in a mini mental. And this is very simple stuff. It's repeating words backwards, identifying objects, you know, doing a drawing when you tell somebody to. Very simple stuff. And so this chart basically says that the scores at, you know, above 25, I mean below 30 but above 25, they may be in a very early disease process, and they may be there for a while, and then as the score continues to decline, that is directly proportional to their symptomatology, and you can see how it extends out to death. And this is a pretty steady slope until we get down to that only about 5, and then it seems to pick up the pace a little. So anyhow, this is just a little chart showing you how how it progresses, and this for many patients is a 10-year disease process. It's very, very difficult, of course, for both families, and initially for patients when they understand what they've lost, but later on they no longer understand what they lost, so they sort of end up in a kind of new kind of normal, but of course the family is always aware of what has been lost.
I know this is sort of a mishmash, but I wanted to talk about seizures as well. And of course, seizures, as you know, are a unexpected temporary electrical adverse event in the brain. And for those of us who are critical care nurses, seizures are really the dysrhythmias of the brain. They're dysfunctions in the way the signals are being transmitted, much as atrial fib or ventricular tachycardia or so forth. We tend still to hear the language grand mal and maybe petit mal, but mostly grand mal seizure, and those are not really current terminologies. So this is a way to think about, this is the correct way, the correct language to use about seizures and how they are currently classified. So the very first, we'll look at generalized first. This is the one we more commonly see, and especially in critical care. Now, a generalized seizure involves the whole brain, and this patient does lose consciousness. So it may start at one spot, but it very rapidly progresses to the rest of the brain. Now, of the generalized seizures, there are 4 subtypes. The very first type is the tonic-clonic, or what we used to call grand mal. Loss of consciousness is involved here. The body stiffens first, and that is the tonic phase, and then jerks, and that is the clonic phase. So as you know, somebody who's having one of these seizures has rapid jerking-like motions of all of their extremities and their whole body. There's nothing that this side is worse than that side. It's definitely very, very generalized. These patients definitely lose consciousness and usually lose control of their bladder as well. And we know that the only real care from a bystander during this type of seizure is protecting the patient against injury. We do not shove anything into their mouth. If they're going to bite their tongue, they're going to do it at the first moment of the seizure, and we just protect them. Of course, medically, we may be also giving them medications. Now, an absence seizure is a petit mal, what we used to call a petit mal seizure, and this is this like staring off into space, and the patients, well, they're not unconscious. There's something definitely impaired about their consciousness or their wakefulness, and they're non-responsive to outside stimuli. These are typically self-limited. They occur, and they're usually diagnosed in late childhood or early adolescence, and in most patients do disappear after about the age of 18. So they're pretty much concentrated in, say, middle school and high school age folks. Another type of seizure is called a tonic or atonic drop attack. And what this happens is the patient just goes down. They lose consciousness, and their whole body stiffens, that's tonic, and they drop, or their whole body just relaxes, and that's atonic, and they drop. These are not common. I've only seen one of these in my career, and it was in a patient who was an alcoholic. Um, yeah, that's all I got to say about those. And then the last one, which again, the not necessarily a full loss of consciousness, is a myoclonic seizure with sudden muscle jerks. And in fact, all of us have probably experienced something like a very brief myoclonic seizure. And as you know, there is a time when you're shifting from one stage of sleep into another where sometimes your whole body jerks and it sort of wakes you up. That's a myoclonic type incident. A myoclonic seizure is a little more dramatic than that, but again, this is not very common. So that's our generalized seizures. Now, where the classification gets a little more confusing is in the partial seizures. So a partial seizure starts in one area of the brain. In most instances, it's limited to that area. Now, you can subdivide partial into simple and complex. And in a simple partial seizure, again, your symptoms are focal because this is just one part of the brain, and the patient is aware of what is going on. In a complex partial seizure, there is an alteration in awareness, not unconsciousness, but there's some alteration, lack of responsiveness in either awareness or even behavior. Now, the complex is more likely to spread throughout the brain, and as it spreads from one area to another, then it can become a generalized seizure. So once it leaves the local area, it can become a generalized. A simple seizure, a simple partial seizure with retained awareness also has the potential of generalizing and then moving into a generalized seizure. But typically these seizures remain in the simple, in the partial category. You can see these seizures sometimes in patients with a very discrete type of head injury or maybe a metastatic lesion in the brain. I remember, and this happened to be my own mother, who had metastatic colon cancer, and while we never diagnosed it involved in her brain, late in her life, she began to have what we used to call Jacksonian seizures, which we would now call simple partial seizures. And a Jacksonian seizure is your arm would start, your hand would start to jerk, and then your forearm, and then your upper arm, and then your shoulder. It was a marching seizure, and that's an allusion to Andrew Jackson's marches during the, I guess he was War of 1812. But and I clearly remember that my mother was very aware she was having a seizure, and it was distressful for her. It was very anxiety provoking. So that's the kind of thing that would be a simple seizure. A complex seizure might be some very focal type of activity, but maybe with some vocalization. Now, another kind of seizure, which isn't really in the classification system, is the febrile seizure. And most febrile seizures are benign seizures, and up to 3 or 4% of all children less than 5 years old can have experience in them. These most frequently, though, are between children who are about 6 months old to 3 years old. What's very, very, very important about these seizures is they typically, again, occur with a high temperature, so like 104-ish. These are non-focal, so they're generalized, and they're short and self-limited seizures. And when they are non-focal and when they are short and self-limited, they do not predict seizure disorders in adulthood. They just appear to be a developmental phase here. So if they're non-focal and they're very short and self-limited, this does not mean this child is going to be an epileptic in their future life. And I think that's really important to help parents understand this, because this has to be very, very scary. I've certainly seen these in children as patients, but never in my own personal life or as a mother. And I can imagine how frightening it would be to have a child who's sick anyhow, and then who starts to have a seizure. That would be very, very frightening. So we can take heart in knowing that if these are these non-focal, very short, self-limited seizures, they are not predictive of disease. However, if a child has a complex febrile seizure, which is longer, they may be more often, and they may have focal characteristics. That may be predictive of a future seizure disorder. And what it could mean is that the seizure disorder is just beginning to manifest itself during this time of physiologic stress. So the short, non-focal, self-limited, not predictive. A longer seizure that occurs more frequently, which has focal characteristics, may suggest, doesn't automatically suggest, but may suggest the presence of a seizure disorder. Now this is a look at the spinal cord and its coverings, which are exactly the same coverings as of the brain. So what we're looking at here is three coverings, the most external of which is the dura mater, which is a thick leather-like covering, then the arachnoid mater, and then the pia mater. And the pia mater is a very, very fine, thin membrane over the brain itself. Now, as we know, there are spaces between the dural mater and the arachnoid space, called the subdural space, and between the arachnoid and the pia, which would be the subarachnoid space. As we know, blood can accumulate in either one of those spaces. In the subdural space, it's typically from trauma, and in the arachnoid space, subarachnoid space, more typically from a vascular bleed. Okay, now let's talk about circulation of central spinal fluid. And this is the pathway, and we can look at the picture next. But we have lateral ventricles going through the foramen of Monroe. And remember, foramen is a word for window, so this is a very small opening. Into the third ventricle, then through the aqueduct of Sylvius, another small space, the fourth ventricle, and then through two other foramen, Luschka and Magendie, and then down into the cisternal and subarachnoid space. Now, what's important about CSF is it is one of the only products in the body that is produced without any feedback system. So production of CSF occurs at a constant rate. Now, we can upregulate the production of CSF through a tumor in the choroid plexus, but we have no mechanism to downregulate circulation of CSF. So if we have obstruction in any of these spots, then that obstruction may interfere with the movement and reabsorption of CSF, but nothing happens to turn it off. And that can be one of our main sources of increased intracranial pressure. For instance, when we're talking about the subarachnoid space, the arachnoid mater is called that because it's very vascular, and to the original gross anatomist, it looks sort of like a spider web. And in the subarachnoid space, that's one of the places where a lot of reabsorption of CSF takes place. Well, the subarachnoid space is clotted up with accumulated blood that will interfere with the reabsorption of spinal fluid and hence can lead to an accumulation of spinal fluid. So here's a picture telling us again, so we can see where these small, there are some small, very small spaces that the CSF has to go through. And so clearly, if there's an obstruction in any of these very narrow spots, that is going to interfere with the mechanics of the movement of CSF, which ultimately dumps into the venous system and then in the lymphatic system. Now, this choroid plexus in the lateral ventricle, that is where CSF is actually manufactured. When we talk about hydrocephalus, which would be an increased amount of CSF, we can have communicating and non-communicating hydrocephalus. And a communicating hydrocephalus is one where the all those pathways that I just showed you are open and non-obstructed. So a communicating hydrocephalus might be related to an overproduction or under reabsorption of CSF, but it's not related to a structural abnormality. Now, non-communicating hydrocephalus is indeed related to a structural abnormality. And of course, we do have ways of taking care of this in an acute or a chronic stage. For an acute increased accumulation of CSF, of course, we can put in a CSF drain, and but that's only an acute care intervention. And for a chronic non-communicating CSF, rather than being able to fix the structural defect, which is usually not possible. These are patients who have shunts put in place that help us divert the CSF into the circulation of the body, either into the peritoneal space or into the right atrium. And those shunts are very frequently placed in childhood, and they actually have little valves that may be located behind the ear that can be manipulated to help promote drainage if the CSF begins to accumulate. It's because we have these shunts now to allow this continuous release of the CSF fluid that we no longer see hydrocephalic children. Even when I became a nurse back in the early 70s, we still had some of these hydrocephalic children for some reason I've never understood. We 22-year-old young student nurses spent like a week taking care of these children with their head dimensions may have been, say, 30 inches around, 36 inches around. I mean, just a very very impaired and disabled children. Well, we don't see that anymore because we have a way to fix this problem. When the CSF is not being absorbed well, there are potential alterations in the blood-brain barrier as well. Now let's think about the circulation of blood through the brain. And of course, we have two basic circulations. We have an anterior and a posterior, and those circulations do connect through the communicating arteries. So even when a part of a blood vessel in a brain is blocked, yes, things distal to it, if it's a distal branch, are blocked. But if it's like within the circle of Willis, a certain amount of backfill can take place to protect the brain. So the anterior circulation consists primarily of the carotid arteries and the circle of Willis themselves. And of course, two of the big arteries off the circle of Willis, are the cerebral artery, the anterior cerebral artery, and the middle cerebral artery. And these are the areas of the brain that those protect, or serve. Of course, the middle cerebral artery is very frequently one of the sites of an ischemic stroke. Now, the posterior circulation is with the vertebral arteries as opposed to the carotids. And the separate vertebral arteries join to form the basilar. And then we have the cerebellar arteries and the posterior cerebral arteries. So if we look at a picture here, of course, you can see the circle with the anterior communicating arteries, the anterior cerebrals, the middle cerebrals, which are very large and very dominant. Then we have communicating arteries that connect the anterior circulation, the circle of Willis, to the posterior circulation. And the primary arteries there are the basilar arteries and the vertebral arteries. You can see that the cerebellum is supplied by the posterior circulation. The anterior and temporal parts of the brain and the cerebral cortex are supplied by the anterior circulation. Of course, we all know that in critical care and in trauma, post-trauma care, that increased intracranial pressure is one of the most serious complications of a head injury and something that we're always looking for. One of the things to remember about the behavior in an adult, the Monroe-Kelly hypothesis applies. And what the Monroe-Kelly hypothesis said is that, well, we have three components to intracranial pressure, and all three of these contribute to it. So the amount of blood, the amount of CSF, and the amount of tissue itself. Now, in an adult, those components are housed in a closed box. In a young child under 18 months of age, because their sutures haven't closed, they have a little more tolerance for variability in these compartments, but in an adult, our skulls are closed and tight, and we don't have the ability to adapt at all. So an increase in volume of one intracranial component must be compensated for by a decrease in one or more of the other components, so the total volume remains fixed. So somebody that has a communicating hydrocephalus has an increased amount of CSF, then the tissue is going to be compressed, or the blood vessels are going to be compressed to restrict blood flow through the brain to uh, try to maintain an even volume and therefore an even pressure. Clearly, that only works for a while. And then if one volume gets too large and it can't be compensated for by the others, then we have a situation we call increased intracranial pressure. So what are some of the mechanisms the body uses to adapt initially? Well, one is to try to shift some of the CSF from the cranium itself to the cistern and to the spinal cord. The other is that the venous system will contract, so it'll have less volume within it. When these adaptations fail, however, then the volumes and the pressures both increase. And this is the relative balance of these volumes within the skull. 10% of the volume is CSF, 12% is intravascular fluid, and 78% is tissue. And of course, the least able to adapt there is tissue. So you can see where if you have an increase in tissue, like a tumor, how it's very difficult. If that's a large tumor, it would be very, very difficult to reduce enough CSF or intravascular blood to accommodate the size of the tumor without changing pressures. And this is the classic Monro-Kelly curve. This is showing how a relatively small volume increase can radically increase intracranial pressure. So the way to look at this is that this is a normal intracranial pressure. If you add even 1 ml of fluid to that brain, there is no change in pressure. You add a second ml, no change in pressure. You add a third ml, and now you've shifted the pressure from 8 to about 15. And that fourth ml can push it up to 25 or 30. So it takes very small volumes to affect a very significant pressure increase. So this is what's going on when we increase those pressures within the brain. So let us say what we have here is a traumatic injury of some sort, or maybe a bleed. One of the initial responses, of course, of the tissue, part of the inflammatory response will be the formation of edema in the tissue of the brain itself, which will increase the intracranial pressure. That increased intracranial pressure, part of it physically will be compressing blood vessels, but blood vessels will also try to constrict to offset the increase in pressure. This will reduce cerebral blood flow. When you reduce cerebral blood flow, then of course you're going to reduce oxygenation. Brain cells may die. As brain cells die, you will have more edema. With the edema, you will have increased intracranial pressure. The only way now the brain has to expand is downward, and downward involves the brainstem and the respiratory center. As we depress respirations, of course, we accumulate CO2. Guess what CO2 does? It vasodilates, which is going to increase intracranial pressure. And then, of course, ultimately, if we do not correct this situation, the patient will die. So more than pressure, the reason we want to control pressure is because we want to optimize blood flow. We want that patient to receive his brain to receive the oxygen and glucose it needs. So 20% of all of our blood flow at any given of our cardiac output goes directly to the brain. Now, the things that can affect cerebral blood flow, the single biggest affector is arterial pressure, and that's why when we're talking about calculating a cerebral perfusion pressure, we actually subtract the ICP from the mean arterial pressure. Now, autoregulation also obviously influences arterial pressure. Now, if the patient becomes acidotic, either from low blood flow in the brain and local acidosis or systemically acidotic, then that is going to cause vasodilation. And so acidosis itself will diminish blood flow to the brain. Alkalosis, systemic, or I can't think of a local situation, but systemic alkalosis can actually cause vasoconstriction. And we actually sometimes, in some patients, in an effort to reduce their ICP, make them alkalotic via hyperventilation. And this is the reason we do this, is because it will cause vasoconstriction and help control that one compartment of the brain. So the problem with hypoxia is you have a double whammy, because with hypoxia, the brain is going to try to increase the blood flow, so blood vessels are going to be dilated, but the dilation is going to end up increasing the pressure, and you're going to get into this irreversible cycle, which ends up with not delivering oxygen to the cells. Now, to calculate a cerebral perfusion pressure, you've probably all done this. You take the mean arterial pressure minus the intracranial pressure, and that equals the cerebral perfusion pressure. So we want that CPP to be above 80 is optimal. Below 80, there may be ischemic changes. Usually, therapeutically, we'll be trying to at least shoot for 70. Once you're down to 50, there will be brain damage, and if you're down to 30, actually brain cells will die. So how do we manage increased intracranial pressure? Well, one of the ways, as we all know, of course, is to keep the head of the bed elevated. Another one, believe it or not, is the way we stabilize trachs. If we are using trachs that straight, whether they're ties, which nobody uses anymore, the little Velcro belts, if they're too tight, they can actually impair jugular outflow. And you don't want to impair jugular outflow, because that's one of the ways the brain gets rid of excessive blood and CSF. Same thing with IJ dressings. If an IJ dressing compresses the jugular space, or if, Lord forbid, there is an occlusion in a jugular catheter, that will result in increased intracranial pressure. And of course, we want to keep the head and neck well aligned. If a patient's head is drooping to one side or the other, that may adversely affect jugular outflow. These are activities that increase intracranial pressure, and most of them you're very familiar with: coughing, suctioning, seizing, or straining. So the last thing we want to do with a neuro patient is tell them to put both feet flat on the bed, and on 3, we will all move up in the bed. Boosting a patient in this manner is actually very, very dangerous to both the patient and yourself, because chances are when you're boosting that patient up, you are holding your breath, so you are exerting a Valsalva maneuver. Increased intra-abdominal pressure, which we talked about extensively earlier in the semester, does also have the potential for increasing intracranial pressure. The use of restraints increases intracranial pressure. Just the act of repositioning may increase intracranial pressure. Of course, noise and conversation also increase intracranial pressure. We have several different ways of managing it. One, of course, is ventilation, and one of the things we have to really pay attention to is to not use excessive PEEP, because excessive PEEP can, as you know, increase interthoracic pressure. Thoracic pressure can increase pressure on the great vessels. Pressure on the great vessels can impair outflow from the jugular tract. Again, hyperventilation is a strategy that is used, and this strategy goes in and out of popularity, so it is a strategy that is used, though, to constrict the venous vessels in the brain. And while you will never ever hear me recommend instilling anything into an ET tube such as saline, it is appropriate in some patients to instill lidocaine into the ET tube prior to suctioning, and these would be patients who had an extreme increase in what we'd call Cannon waves or A waves following suctioning in their intracranial pressure readings. Obviously, you want to maximize O2 delivery and O2 saturation. Now, of course, we very frequently use sedation or muscular blockade. We're going to control that blood pressure. Obviously, we don't want these patients seizing, and of course, we know we have CSF drainage devices available. When we give diuretics to help decrease intracranial pressure, the best of these diuretics would be an osmotic diuretic such as mannitol. Non-osmotic diuretics such as Lasix can help, but the osmotics definitely are the best. And then sedation, neuromuscular blockade, I've already mentioned. Barbiturate coma is very seldom used anymore, but it's still a viable possibility. We want to help control their blood sugar. And of course, one of the very important things we know now is that if we can do therapeutic chilling on these patients, it will minimize their brain damage. So controlled hypothermia is very, very positive in both brain injured patients and in post-heart attack patients. Well, thank you very much for your time and attention. I will also post a non-narrated version of this show in case you want to see it without the automatic timings included. Thank you.